And thanks, Professor Winnie, and for Professor Ahmed Tahwir for inviting me for this very elegant Congress. I will try in the next 20 minutes or so to embark you in different African countries. Actually, I will not be able to cover all Africa in 20 minutes, so I selected around 14 countries and see what is the situation of transplantation in these places. Actually, to enhance the transplantation in Africa, we have challenges. These challenges are two main things: the needs and the ethics. And we have data from around 14 countries that I will try to present. And we have practical approaches. This will be the second part of my talk, dealing with how to overcome the obstacles that we will see together. Could we cooperate together on local society-based mutual support, or on Afrin-based that I would prefer, or on TTS more global-based, or ISN more global-based? Let's embark and see what is the estimated global prevalence of CKD according to the ISN Global Atlas in 2017. And you will see that Africa is only 8%. But actually, I think this is an underestimation of the number. I expect that we are not less than 12% like other areas in South America or in Asia. This is also reflects our under-registration. The epidemiology in Africa, as you see, the CKD in sub-Saharan Africa, age between 20 and 50, primarily due to hypertension and GN with late presentation in 75% of cases. So it's very important to go early recognition, because renal failure means, for unaffordable people, means death. The global prevalence of nephrologists is another problem in Africa. And you see here that in some area here not available according to the same atlas that I told you. And in many areas we have few nephrologists as compared to USA or Europe or Australia, for example. The deceased donors according to the WHO 2011, and when you look to Africa, you find almost 0 to 4, while deceased donation in other areas of the world is different. And we have the treatment of transplantation as a part of the spectrum of treatment of renal failure, very little in Africa in comparison to other areas of the world. So we have a real problem. And this problem could be more exaggerated when you see how much other countries' rate of organ donation in Spain, 70%, in USA, in United Kingdom, or even in Turkey. And this is the need. But when we look to the need, we should not forget the ethics. Because the founders of our profession, starting from Hippocrates, going to Avicenna, and going to Declaration of Istanbul Custodian Group, stress on the ethics of transplantation. So if we want to solve our problem, this should not be on the expense of ethics, because remember always what Albert Einstein was telling: try not to become a person of success. Success is making transplantation anyhow, but rather try to become a person of value. So we need to do transplantation with value. And therefore, we should respect all this data coming from the Transplantation Society, from Istanbul Declaration, about organ trafficking and commerce in organs, etc. Therefore, this is an example of how African representatives are present. Many of them are present in this hall, by the way, and see the International Transplantation Network data Congress in Istanbul, 29 to 31 May, about Africa transplantation, and from which I will present the data of the 14 countries that I will embark with you. This is the data from Ivory Coast, who will be our next president, our next venue. And you see here the prevalence of the 14% of disease are linked to renal complication, 700 adult patients currently on dialysis, very few number. And you see here that the regulatory framework, we have a law, this law, 1991, which is with another decree on 2012. And we have situation analysis telling that 30 cases has been transplanted only since 2012. So we have very little transplantation. But we have some achievement on the laboratory level, as Professor Gamal was just telling, in trying to do all the parameters to evaluate a transplant in depth and to avoid even the virological complication and bacteriological complication parasitic that may occur after transplantation. Now in Cameroon, the regulatory framework is a draft law concerning organ transplantation pending finalization. Implementation procedure amongst which consent types are not yet elaborated for organ transplantation, except for blood transfusion and IVF. Since activity is not carried out, there is no available information on the matter, and there is need of defining roles and responsibility of the health authority involved in donation and tissues. And the milestones here and achievement and stresses are the appointment of a new minister who is trying to increase the population on dialysis, because now that they have 15 hemodialysis centers, and this is an economic burden to the government and the country, so they should embark more into transplantation, and this is Sangamelina Regional Hospital, a place for possible transplantation. Now going to my country, Egypt, which is the earliest physician in the world coming from Imhotep, but in spite of this, we don't have cardiac or pancreatic transplantation till now. We started our transplantation in 1976 with the kidney, and the partial liver 1981, and the law in 2011, but we don't have cadaveric transplantation. Why? Because of 6 reasons. First, maybe religious debate about the brain death. Second, the people are not accepting the concept of brain death, and the media has got a negative role in this, with films like Coma and other films telling that the doctors are stealing the organs. And many intensivists even disagree over the definition of this, and arguments supported by some cases of prolonged coma, like Ariel Sharon in Israel. We basically were pharaohs, and mummification is rooted in the pharaoh's practice and was linked to religious beliefs. And when you go to Egypt, you see these 4 pots in which they put the viscera of the dead. And the ancient Egyptians believed that by burying the deceased with their organ, they may rejoin with them in the afterlife. So if you take the organ, maybe it would be a problem, according to the ancient Egyptians. 70% of the healthcare expenditure is coming from out of pocket in Egypt. So this is, again, another problem. And we try to overcoming this by telling to the authorities that you have heart failure mortality by around 80,000 per year, and liver failure mortality around 20,000, more than 20,000 per year, and respiratory failure, etc., and overall and organ mortality around 150,000 per year. That could be overcome if you go for cadaveric transplantation. This is a way to convince them. Now let's embark to Ethiopia, and we see this nice hospital, which is the transplant center, and this is the transplant surgeons, because they were the one in Istanbul presenting, but they forgot the role of our eminent nephrologists. Among them, Dr. Momina is present here in St. Paul Hospital, first transplant 2015, which took a preparation for 3 years, and now totally 114 transplant, 32 transplant a year in Ethiopia, and now almost 1 transplant every week. So they are doing a great job. Senegal. Increase in the supply of care with growth of public dialysis center from 6 to 17 in 5 years. And the existence of peritoneal dialysis, which are all free. Donor living only in Senegal. There is no cadaveric also. Transplantation only in public service. These are the laws in 2015, and very strong penalties for anybody not respecting the law. This is very important. Nigeria, Dr. Ifeoma give a fantastic presentation about the transplantation in Nigeria. They have large pool and stage renal disease. The cost of transplantation is a big problem for the patient. Only the rich can afford. Immunosuppression and follow-up are difficult to maintain also. But they are trying to make transplant registry through the Nigerian Association of Nephrology, And it is mandatory for center to report any activity to the central registry. They have 14 centers, and the earliest transplant activity was in 2000. All transplants till date are living donation. They don't also have cadaveric transplantation. This is Saint Nicolas in Lagos, the first transplant, still very active in 2019, with more than 300 transplants up till now. And the second active will come from Abuja, and we have more than 50 per year. So Nigeria is doing a good job. Uganda. In June 2014, MOU, Mulago National Referral Hospital, with India, cooperation. I mean, they started to make an MOU of cooperation between India and Uganda, and over 150 living related transplants mostly are done in India. Actually, they have a small number of nephrologists, less than 8, but under training we have 3 more, and the prevalence of end-stage renal disease is 15%, with 5 dialysis centers with not much patients, but they are improving. In November 2014, creation of organ transplant unit as a part of renovation and re-equipping of Mulago National Referral Hospital. 2015, drafting the organ transplant bill, currently in the parliament, expecting by January 2020, start a living donor kidney transplant. Somalia, since 30 years Somalia in war. So all the people will go to be treated in the hospital as war injuries. No time for transplantation. There are no any activity in the Somali country, like donation activity, transplant service, or training program on transplant procedure. So they are in a mess, but we hope that these plans will change starting 2019-2020, according to Dr. Mohammed Yusuf Hassan, who gave this presentation. Tanzania. Tanzania established organ transplantation in 2017, and this is the algorithm how they go in transplantation. The Ministry of Health oversees the kidney transplant in the country. Consent, they do only living related, and the donor age less than 60. Written consent is mandatory, and the law is not yet established in the country, and there is currently ongoing effort to develop it. And these are the 2 hospitals in Tanzania in which they perform the transplantation. Muhimbili National Hospital, doing around 5 per month, and Benjamin Makaba Hospital. Ghana. There is the decree since 2010, National Guideline for Human Donation and Transplantation. The Ghana Organ Transplant Committee technical group had been formed to supervise the activity of the Ghana Organ Transplant Association, and the main members mainly in the tertiary hospital, and this is the biggest hospital, called Korli-Bu Teaching Hospital, in which most of the transplants are done, but there are other areas in Accra and other places. No organ transplant registry yet. Live organ donation is commonly done by the first generation relative with the help of visiting surgeon. 16 successful kidney transplant has been performed in this hospital since 2011, very small number. And the last of which, unfortunately, occurred 3 years ago. So they stopped the program for unseen reasons. Sudan, great efforts in Sudan transplantation by Professor Omar Abouda and his colleagues. Barcelona diploma in organ procurement by Sudanese expert like Dr. Abu Bakr Abdul Wahab that is here in the present. Active living program now is in at least 3 big hospitals in Khartoum, Ahmed Qasim, Ibn Sina, and they are doing very important living related, waiting activation of cadaveric program. Again, Tunisia. Cornea, Tunisia is the earliest country to do transplantation because the cornea, 1948, they started before all the others for the cornea. In the kidney, 1986. And here you see heart, liver. I'm ending by the 2 countries in which there is cadaveric transplantation. Tunisia is one of them. How they did this, we'll see soon. They have more than 11,000 chronic renal failure patients with increased annual. On the kidney list and on the liver list, heart list, people die on the waiting list because they started in 1951 authorization in hospital, and 1991 a very precise legislative framework with the medical guarantees and reinforced respect of the ethical principle related to the activities. And again in 1995, public administration under the authority of the Ministry of Health, Centre National pour la promotion de la transplantation d'organes. This has been established in 1995, a very important center to see all these activities, and they have the presumed consent for deceased donor. This could be an example for Africa. Now they have 25 sites, 5 of them for kidney, 4 for liver, 1 of them is for pediatric, heart and lung transplantation, cornea, bones, and bone marrow. This is a very good example. South Africa, and this is Professor Elmi Muller doing the difficult. The difficult is to transplant the difficult cases. Even the HIV cases here. 51 cases are transplanted. Okay, no problem. We can transplant and they can die. But see, how is a 5-year survival? 5-year survival for the patient, 82%. For the graft, 77.5%, in spite the cases are very difficult cases. So this is a very outstanding example. Now we finished our tour, and let's go how to become or overcome these problems and what is the practical way. Let's go and see. Would we like to have opting out a consent? I mean, everybody is donor until he says no, like these countries, and Tunisia also is one of them. Or opting in, I mean, you should have your will to be a donor, yes or no, or mixed like other countries. Those opting out, like the Spanish model and Portugal, have got the highest rate of transplant, of course. And if you hesitate, you are less. But okay, let's say even opting in is not bad. Why not moving? Huh? Okay, you can move from your side. And anyhow, this is so what are the basic requirements to start a transplant service? Political and economic support, very important political support. A wish from the authorities to give you a law and to do independent ethical assessment committee and to have a national database and registry, validation of the allocation system, nephrologists and surgeons with experience, training, ICU staff, effective harvesting and implantation teams, recipient education, compliance, personal hygiene and clinic attendance, department of biochemistry with all the biomarkers, etc., radiology department with full complement of facilities, transplant pathologists like Dr. Wissam, continuous training of the team transplant. And this is an example of the national database of hemodialysis centers in Egypt. And this is an example of how we could be trained, even the senior people, on brain death. And this is a way of getting training on brain death, because not everybody is knowing what are the criteria for brain death. Public involvement is very important. Engagement of members of the public in strategic decision. Getting the celebrities like football players, like actors, in propagating and telling that they will give their organs when they die. And trying to connect with the international society. This is an example of the TTS coming to Cairo in our regular meeting to promote the cadaveric transplantation. The DOPS, and I see here the president of the ISN, we got a photo with him, he's here in this meeting. And International Transplantation Nephrology in Istanbul that I took many slides from it. And a local society's mutual support. Our society goes to Libya, goes to Addis, try to publish some data about the parasitic infestation in organ transplant recipient, because this could be peculiar to Africa, and how government can support, and the HOPE Act by Barack Obama, who is originally from Kenya, and how he led the American goal for getting organs from HIV positive patient to HIV negative. And I think this is the example that was done in South Africa after that. And the possible solution, I can summarize them in this slide. Religious support, whether we are Muslim, there are fatwa, Christians, the church is supporting, no problem. Giving life is rewarded. Governmental support, get a law, establish national organ procurement center with appropriate registry, expand the funding resources, incentive for donor families could not be always money, but it could be respect, anything that makes them proud of donating their organ. social support, and organ mortality, and the media focus on new life of the recipient that has been saved. Collaboration with the international society is the roadmap. Of course, Afran will take the lead. Extensive training course with bodies like the ITN, Barcelona, etc. Campaigns for doctor, politicians, and celebrities donating their organ and stressing that if you don't do this, your end organ mortality will increase, and you will having people not dying only from renal failure, but from heart failure, from liver failure, from respiratory failure. And thank you very much.